Hello out there. I'm Leslie Randall. I'm a GYN oncologist at VCU Health in Richmond, Virginia, and I am lucky to be the cervical cancer lead trial advisor for the GOG Partners Group. And I have with me a very special guest, a member of our team today, Dr. Pathuri. Hi, Dr. Pathuri.
Hi, I'm Bhavana Pathuri. I'm a GYN oncologist as well. I'm at NYU Langone Health, Perlmutter Cancer Center in New York, and I serve as an assistant clinical trial advisor for ovarian and endometrial cancer, but also have a great interest in cervical cancer. So we're excited to talk to you tonight.
Great, and I'm excited to have you. I hand chose you because I know how much closely that you've been following all of our trials and supporting our portfolio. So welcome. This is kind of an overview of what's happening in the GOG Partners. We're going to get into some of these studies as we talk today, but you can see that we have 3 open trials currently, one in the locally advanced space, one in the first-line metastatic space, and then one in the second-line metastatic space. And you can see that we've closed several that we're going to talk about today. And we've got one FDA approval from these trials and potentially a second FDA approval in January from these trials. And under development and ready to open very, very soon is our first surgical trial, robotic surgery for early stage cervical cancer, which we'll talk about and we're super excited about. So not a GOG partner study, unfortunately, but really based on and building upon the GOG 240 study that was completed by our group and led by Dr. Tawari back in the early 20-teens, was the Keynote 826 study. And this was platinum taxane-based chemotherapy with physician's choice Bev, which is, interesting as it was required in 240 or randomized in 240, with or without pembrolizumab. So if you haven't heard, this trial was positive and led to FDA approval of pembrolizumab in the frontline for patients. And Dr. Pathuri, what was your reaction to this data when it was presented this year at ESMO?
Oh, it was incredible. This was so exciting to have pembrolizumab approved in the first-line setting for cervix cancer. And the approval is for PD-L1 positive cervical cancer that is at least 1, the CPS of at least 1 or greater. But really, really exciting. It met, OS, PFS endpoints, and as well as the ORR was also improved. So really exciting to have the approval of pembrolizumab in this setting.
Great. And, these data were published in the New England Journal. So if anyone watching hasn't seen that yet, you can look that up. Dr. Nicoletta Colombo was the first author of that paper. And that paper is really interesting because, I think because of the work that they did in the second line with pembrolizumab and had that approval for PD-L1 positive, when Keynote 826 was designed, we had a good handle on the importance of PD-L1 in this space. But no matter how you cut the data, really there was a benefit with pembrolizumab. But interestingly, as you said, approved only for the PD-L1 positive. Do you think that's problematic? Are you concerned that you can't give this to your PD-L1 negative patients?
Yeah, no, that's a really good question because in this trial, this represented 89% of the patients. So the majority of them, would be eligible for pembrolizumab in this setting. So I think that, essentially it is useful for all patients. And I know that, we're going to talk later about another trial with cemiplimab. So, and that trial looked at, all comers, and there was, a benefit irrespective, I should say, of PD-L1 status. So, I know that I can hopefully use it in that setting as well. So I think it's not really that much of an issue.
Yeah, I couldn't agree more. I think that maybe somehow we select out, people are wondering, should I save this for later for my patients? And I think probably only we should be saving it for later for our PD-L1 negative patients who may benefit from checkpoint inhibitor down the road. But for frontline patients who are PD-L1 positive, to me, this represents a clear shift in the standard of care. I've heard some concerns about a quadruplet regimen, logistically, cost-effective wise, using all of your active drugs in the first line. I mean, I've heard a lot of these concerns. Like, what do you think about some of those points?
Yeah, I mean, I actually think that, it's important to use all these drugs in the front line. There was a survival benefit, and, cervical cancer is not like ovarian cancer. I mean, this is our, you have one shot to really see if you can treat this. So I think not utilizing pembrolizumab, in the frontline setting after this data has been published and presented and approved, I think is, I think you have to think really hard about not using it. And there needs to be a real contraindication to the use of pembrolizumab.
Yeah, I don't disagree with that at all. And just like you said, I mean, these patients, this is not ovarian cancer. These patients don't have multiple therapeutic options. They don't have long post-progression survivals. Like, this is really sort of your shot to give them a longer life, better quality of life. What about bevacizumab? Do you think this means that we don't need to give bevacizumab, that we can just omit bev from our regimen here?
Yeah, I don't think so. The bevacizumab was given in this trial per investigator discretion. And so personally, I think that, you should continue to use bevacizumab when appropriate. So if if a patient is an appropriate candidate and you would have used bevacizumab, I'm going to continue to use it, and I'm going to add the pembrolizumab.
I think that's a good rule of thumb. If you can use it, you should. And interestingly, in the trial, the breakdown of use was about 60-40, 60 pro bev and 40 omitting bev. And I think that's pretty consistent with what we've seen in some of our other trials. Great. Well, thanks for discussing this really important study. In the GOG, we participated in an ENGOT study that looked at atezolizumab in this space, and this a PD-L1 inhibitor. And this is called the BEAT-CC trial. So in this trial, bevacizumab was mandated. And otherwise, it was a fairly similar design to the KEYNOTE-826. It did not have the PD-L1 biomarker built into the design as KEYNOTE-826 did. So there'll be some really interesting similarities and some interesting differences here when this is presented. So this completed in the summer. So I'm sure we are a little bit away from having some available data for this study, but we had 7 awesome sites here in the US. We only had 7, and they really did the heavy lift of enrolling to this trial. And currently, I think for me, the place where we stand to make the most gains from immunotherapy is in the locally advanced cervical cancer space. So here we have a trial that's led by Linda Duska and Ritu Salani for us here in the GOG, and also a collaboration with ENGOT, the KEYNOTE-A18 trial that randomizes patients to chemoradiotherapy with or without pembrolizumab. And the pembrolizumab is given both during the chemoradiotherapy and as 2 years of maintenance. And this is based on really based on a lung cancer trial called the Pacific trial, showing the benefit of durvalumab maintenance 1 year after chemo-RT for lung cancer that's locally advanced. And they had a similar trial for cervical cancer called CALA, which has completed enrollment. And this is our pembrolizumab study running through the GOG. So this is still actively enrolling. We're really looking to recruit patients. Some barriers to recruitment for this have been, I think, the pandemic. I think our cervical cancer patients have not been coming in at the rate that we've seen them, come in the past, and maybe they're coming in more advanced than they were. We've started to recover those accrual numbers since the pandemic has kind of lessened, or we've had some mitigation strategies. The second barrier is that this is only for high-risk disease. So patients who have smaller tumors, 1B2 to 2B, this is for the old FIGO staging, have to be node positive. And the larger tumors, 3A to 4A, can have any nodal status, but really we're looking for stage 3 and 4 patients here. And there's kind of a few reasons for that, but mostly just to get the outcome quicker. If we include those lower risk patients, you need so many more patients to complete the study, and it's already kind of difficult to get it accrued. So, will this apply to the lower risk locally advanced patients once this data is available? We're not sure. I think that remains to be seen. What do you think about adding immunotherapy to chemoradiotherapy? Do you think that that's kind of ready for prime time? Do you think these phase 3 trials were justified? Did we need more preliminary data to go here?
I think the fact that we now have, randomized phase 3 data in the first line setting, I think this is the next logical step to move it up, to really time of diagnosis. And I'm really eagerly awaiting this data and have my fingers crossed. I would love to see pembrolizumab moved up even earlier.
I think so too. And so having said that, the earlier we give it, the more patients will have had it when they get to that second line space where we were using it. And so here's where we have in our second line now, cemiplimab. And so this was such an important study. This is the only randomized trial of checkpoint inhibition in the second and third line. And this was led by the GOG in collaboration again with NGOT, and Dr. Tewari was our GOG PI for this study. And this randomized patients to single agent cemiplimab, which is a PD-1 inhibitor currently approved for squamous cell cutaneous carcinomas, and versus investigator choice chemotherapy. And here are the options of chemotherapy. And this completed accrual a little over a year ago and was presented back in May by Dr. Tewari. And what were your reactions to these results?
Yeah, these were really so interesting as well. I think it's important to note that this study was actually closed early because it met its endpoint. So that tells you, right, that it was, really, the data was really pretty interesting. And yeah, the median, if you look at the intent to treat group, it was 8.5 versus 12 months with a hazard ratio of 0.69. So, and this is, again, we're seeing a survival benefit, overall survival benefit. So, and this was, across histology, squamous cell and adenocarcinoma. And as we alluded to earlier, this trial was irrespective of PD-L1 status. So I think it would be really important to have a therapy that's approved for all our cervical cancer patients.
Yeah, I think that would be. Especially they're not going to have that opportunity in the front line unless, maybe locally advanced will pan out that it's irregardless of PD-L1, but in the metastatic setting, in the 826, it's PD-L1 positive with our negative patients, even if they are only 10% of that population, if you could give them that opportunity to have access to the drug, if it's going to benefit them in some way. I think there were really a couple really interesting things about this trial. Number one, the response rate to the control arm chemotherapy. And I think that we, in general, think that response to chemotherapy in the second line is probably like 10 to 15%. In this study, it was 6%. It was terrible. So maybe in that post 240 space, chemotherapy does even worse later on. So, we have a tisotumab trial that's randomized to investigators' choice chemotherapy. So we'll get a second readout on another control arm to see if that 6% is consistent. But chemotherapy really is abysmal and no duration of response. So even though we don't have everyone responding to checkpoint, 11.7% of patients that were PD-L1 negative responded to cemiplimab in this study. So that's much better than 6%. And we don't really have all the PD-L1 status for these patients. That PD-L1 data is going to be incomplete because when this study was designed, unlike 826, we're really sure how important PD-L1 positive was. So it'll be interesting to see. This is before the FDA currently with the PDUFA date at the end of January. So we'll know by the end of January what the FDA's decision is regarding these patients for cemiplimab. And I think the last thing that is important about this trial is the quality of life data. So you're a quality of life PI prima, and in all of our PARP trials, we had no detriment to quality of life, and we were happy with no detriment to quality of life. In this trial, cemiplimab improved. The patients on cemiplimab had an improvement in quality of life. And I don't know that we have another trial where there was actually shown to be an improvement in quality of life. I think in LAP2, there was a brief quality of life improvement for laparoscopy over open surgery that was negated later on.
Right.
But
yeah, I think that's a great point.
So, you know, to me, that's very meaningful data for this. So this was really, really exciting. And I mean, I think, you know, you can say, okay, well, if patients get checkpoint earlier, does this even matter? And again, I think it matters, just like you said, for our PD-L1 negative patients or patients who were missed in that front line, they still hopefully will have the opportunity to get cemiplimab.
Yeah, and I think your point about the quality of life is really important because, you know, probably it's related to efficacy, right? If you did treat the disease, you're going to feel better. And I mean, as you pointed out, the chemotherapy was 6%, right? So versus, you know, cemiplimab. So I think, yes, checkpoint inhibitors are well tolerated, but I think they also work. It's a dual story there.
I think you're right. You know, when you think about it, you know, you bring up such a great point. I mean, these are very symptomatic patients typically. And so often you need to see a response that has some durability in order for them to feel better, to improve their quality of life because they have so many disease-related symptoms. Oh, that's a great point. See, that's why I invited you. Okay. All right, so this is what we have going on in the second line space. I mean, we're trying to build on this story. We're trying to build on this anti-PD-1 story. And here we have, you know, a third agent here, balstilimab, that has shown good efficacy. Dave O'Malley has presented this at ESMO recently and showing good efficacy in both a PD-L1 positive and negative population, very similar to cemiplimab here. The combination of balstilimab with zalifrelimab, which is a CTLA-4 inhibitor, may crank up that response rate even higher. In the preliminary reports, it's about 25–26%. So this study is looking at comparing these two regimens. Interestingly, this study is a comparison study, not for efficacy, but more for trying to sort out the relative toxicity when you add the CTLA-4 combo in with the PD-1 inhibitor. Kind of along the lines of the quality of life, like making sure we maintain that good quality of life and we're not trading off efficacy for toxicity. But this study is a high priority and it's just about halfway completed. And this trial was affected by COVID. The enrollment during COVID really dropped off for this study. We've actually partnered now with Latin America to open this trial in an area where cervical cancer is higher prevalence. And, you know, I think that we'll get this done, but we just really need a big push here in the US to get this across the finish line. So that's the end of our immune therapy portfolio. So now that, you know, we've got checkpoint moving in the earlier lines of therapy, now we need something to take its place in that second and third line. And so we have that in the antibody drug conjugate tisotumab vedotin. So tisotumab vedotin is a monoclonal antibody that targets tissue factor, which is pretty ubiquitously expressed on the surface of cervical cancer cells. And it has a linker to which these really small, this is the cytotoxic payload, this little red dot here, and that's a monomethyl auristatin E, which is a microtubular disruptor. So sort of similar to the way taxane would work. But it's a little bit more complicated than a taxane. So this is endocytosed, and the molecule is broken apart in the lysosome, and the payload is distributed into the cell and disrupts the microtubular apparatus and kills the cell. And as the cell undergoes apoptosis, the active drug is released into the microenvironment, causing a bystander effect. And there's also antibody-dependent direct cellular cytotoxicity and cellular phagocytosis. So there's like 4 different ways that this compound is killing the cancer cell, and that's its proposed mechanism of action. So this is our trial, GOG 3023, led by Dr. Coleman, collaboration with NGOT and with our sponsor, Seagen, and they call this, we actually call it Innova TV204. They call it Innovative TV204. So you may hear this trial called several different things, but the bottom line is, here we had an excellent response rate to tisotumab vedotin. And so, Bhavana, what were your thoughts on these data?
Oh my God, these were so exciting. So when Rob Coleman presented these, I was just so excited. Like really, we had an objective response rate of 24% in recurrent cervix cancer. And I mean, what did we say? We said what in our recent trial, it was 6%, right? So that's 4 times greater. And if you look at the CRs, there was a 7% CR, a 17% PR, but look at the stable disease rate, 49%, right? I mean, this is almost a 75%, 3/4 of the patients have either stable or response. And this is, traditionally a population that doesn't benefit, much from chemotherapy. And the other thing that's so exciting about this was that the median duration of response, 8.3 months. I mean, we don't have agents that, in the recurrent cervix landscape, 8.3 months. So I was so excited to have this as an option for my second line patients. And really, I've already utilized it after the approval.
As have we, and I think we've got 2 patients on off protocol tisotumab vedotin. So interestingly, I guess I don't have a slide on it, but let's talk about the toxicity of this agent. This is a new class of drug, and these data led to the FDA approval of this drug September 20th under an accelerated mechanism. We have the TV301 trial ongoing, which will be the phase 3 confirmatory trial, which is designed just like Empower. So tisotumab versus physician's choice chemotherapy. And we put almost 30 patients on in the US and then closed that here in the US with this approval, and that will continue on in Europe and other countries. But, what's the unique toxicity of this drug that we haven't encountered as GYN oncologists before?
Yeah, so I think I'm so happy we're talking about this because it can cause a keratopathy, and you have to be careful with their vision. So just making sure that you're checking in with the patient about vision, dry eyes. They do need, at least an optometrist keeping an eye on their, no pun intended. No pun on their doing an eye exam and really making sure that we're not causing significant toxicity. And also, I think just really understanding that, you can, make sure that patients have the lubricating eye drops and make sure they have the steroid eye drops. And those things really mitigate those side effects. So it's a lot of patient education. And I think that's probably the one area that we, have not been as used to doing, but it does beg for us to really seek out partnership with, and it doesn't have to be an ophthalmologist, it can be your local optometrist at, Costco or Walmart. So it's easy for patients to be able to do that. And I think the other thing that you do need to think about is the peripheral neuropathy is also an issue. So just keep that in mind when you're using this drug because of the microtubule disrupting mechanism that you alluded to. And then I think finally, it does target tissue factors. So keep in mind, bleeding is an issue too. So you have to kind of be on top of all those things.
Oh, you're so good. You hit the top three: ocular, neuropathy, and bleeding. That's great. I think for the ocular, interestingly, for the label, they said that patients need an eye exam. And just like you said, it does not have to be an ophthalmologist. As we know, you don't have high throughput. You can't get in that fast. Every 3 weeks before every infusion. And that's seemingly a little bit restrictive. I'm a little bit glad they just put it in the label, because then insurance is probably more likely to pay for all the eye exams, which is a concern that a lot of us have had, especially in this population. The second is the eye drops. I mean, they really do work. And it's 3 eye drop regimen, right? So the lubricating whenever, all the time, period. And while they're on the drug. And then the steroid is given day 1, 2, and 3 in the infusion. And then vasoconstricting eye drops during the infusion. And interestingly, they need to wear like a cold pack. So how we do with, pegylated liposomal doxorubicin with the hand cooling and the feet cooling, we hear you're doing the eye and the bridge of the nose cooling for the epistaxis, the bleeding, as you mentioned. So I think, once we get used to this, we'll be able to give this drug with a lot more confidence and not be, the second thing is that most of this eye toxicity is reversible. About 80% of it's reversible. So eventually, in my mind, we're going to look at this like we did with Taxol, with the neuropathy, and we're very comfortable monitoring for it, holding the dose when it starts to develop, dose reducing. I think this ocular toxicity will be very, very similar here. The neuropathy with this drug is a little bit interesting because sometimes it can be motor, muscular, and some patients have been found to have some weakness, but they've responded to physical therapy, which is not too terrible of an intervention. Interesting, but hopefully, I'm hoping that people will use this medication because I think it is clearly active, and as you said, much better than 6%, no question. So this is where we're going with tisotumab vedotin. So this group, and probably a lot of people watching this now, helped us complete a large study here in both both second line and frontline cervical cancer. And you can see on the left here 3 dose escalation cohorts for tisotumab combinations with other drugs that we know to be active, pembrolizumab, carboplatin, and bevacizumab. And then even kicking out expansion cohorts in the front line, TV Pembro and TV Carbo, and in the second line, TV Pembro and TV Weekly. And so we've been getting some results back from this study, some preliminary results presented by Dr. Monk at IGCS on the escalation cohorts, basically showing that you could give all 3 combinations at the standard dose and schedule of the drugs as single agents. So you didn't really have to dose reduce any drug. And these are the adverse events of interest that you so eloquently outlined: the ocular, the bleeding, and the neuropathy. And this is the incidence of those toxicities from Dr. Coleman's single agent tisotumab trial. And you can see that these are fairly comparable to the drugs being combined. So these are well tolerated as combinations. So where do we go with that? Dr. Vargo presented some very early preliminary data on the expansion cohorts, showing, can you see this little arrow here? I hope so. Can you see my arrow?
Yeah.
Maybe, oh, awesome. Great. I didn't know if others could see this. So here the confirmed response rate of 55%. Now this is in the front line. So this is comparable to what we saw in GOG 240 and Keynote 826. And so I think here we're going to need a control arm to interpret what that efficacy means. But in the second and third line, you just got really excited over a 24% response rate. But here you've got a 38% response rate when TV is combined with Pembro, and this is PD-L1 agnostic. So we don't yet know what the PD-L1 status of these patients is. And so maybe TV leads to better sensitivity to Pembro. Who knows? We don't know. This does not definitively tell us that. But, for me, that was more than I expected to see. And so I'm interested to see where this goes as we enroll more patients and get more mature data in this data set. What are your thoughts about these combinations?
Yeah, no, I think it's really interesting, right? I mean, it almost if you look at the confirmed response rate, it's really additive of Pembro and TV. But what's really cool, look at the duration of response is 13.8 months. I mean, that's incredible for
over a year. It's incredible,
right?
Over
I mean,
a year, recurrent cervical cancer, absolutely.
So,
and I mean, and fairly well tolerated. You know, here you can see the toxicity, almost all of these adverse events being grade 1, 2, just really well tolerated overall.
Yeah, I'm excited. And, and I think, this is a small cohort, but certainly begs for further investigation, both in the front line and in this later setting. So we'll see what happens.
Funny you should say that. So our investigators who are running TV205 will be opening one last arm of this study because there was curiosity with these results. Like, what would this look like if we replaced Taxol with tisotumab in the Keynote 826 GOG 240 space? So this arm will be designed like 826. So this is platinum, tisotumab, with or without Bev per physician's choice with pembrolizumab. So that we'll get some toxicity data here, and where this goes, there's some discussions about, what do we do with this data moving forward? And I think you can kind of infer where this might be going, but this would be really interesting. And I think that it's something that may be welcome to patients. Maybe this is less toxic than Taxol, or maybe it works better than Taxol. I don't know. I think that's why we do these trials.
Yeah, that's right. And I think we're going to always get the criticism, well, we're putting all our agents up front. But if we can get, right, if we can improve survival, if we can get, then we should be doing it. So, let's see what the data shows and we'll take it from there.
Yeah, I think you're spot on. And as immunotherapy moves up earlier, and we have to find what's the role of tisotumab. And what do you think about sequencing, by the way, just to before we get away from this discussion on chemotherapy, the immunotherapy, tisotumab? And I've heard a lot of discussion about which one should you give first, which one should you save? What do you think about that?
Yeah, I mean, now that Keynote 826 is, I think it is a new standard of care in cervical cancer. And so I will utilize pembrolizumab, in that first line. And then in my second line, I will use TV. And however, if they're IO naive, like meaning they were the 11% that couldn't get the Pembro, then I would use Pembro in that setting. Or if, I'm sorry, I would use cemiplimab when approved, right? And then use TV after.
I think that's right. Yeah, I think if we look at other disease outside of GYN, I don't think anyone's really shown this definitively, but in general, the earlier you give the checkpoint, the better it seems to work. And so I think the patients, the sooner they can get it, the more they will benefit from that. And that probably should be our goal. But yeah, no data is definitive on that. But I think that's I have the same thoughts. Well, here we go. We're going to finish up with our surgical trial, our first surgical study. This is really exciting. This is really exciting for me. We worked really hard to get an unrestricted grant from Intuitive Surgical for this study. This slide actually says Intuitive is the sponsor, but that's really not the case. The GOG Partners is the sponsor and is actually putting up several dollars from their foundation to support this study that's led by doctors Kristen Bixel and Mario Lateo. And this is a phase 3 study of robotic versus open surgery for cervical cancer, and we call it the ROCC trial. So we are super ready to rock and roll with this study. This allows for tumors up to 4 centimeters as measured by MRI. We're not trusting clinical exam. I think we all know that we grossly underestimate tumors on that exam. And so we're doing this based on MRI. Patients have undergo a one-to-one randomization to open a robotic hysterectomy with lymph node dissection. There's all kinds. I mean, we all know the lack data. We all know the concern for more recurrences and worse survival in the patients undergoing minimally invasive surgery. And so there are a lot of safety features built into this study to, if it's showing that robotic surgery might be, if it's trending towards being harmful, this study will stop at an early interim analysis. We felt that was really important to protect patients. The second thing is we will mandate a tumor containment method. And so there are different ways to contain the tumor. This is just showing you one way of closing the vaginal epithelium from a vaginal approach over the tumor before the vaginal colpotomy is made intracorporeally, and then you can basically make it like a little sac with a purse string and then pull that out through the vagina. This was studied retrospectively by the SUCCOR investigators, and they showed that if you do minimally invasive surgery with a protective colpotomy, that the outcomes were more similar to open. And there in the green trend line there, you can see MIS without that protective colpotomy. So it appears that this might be a significant factor contributing to those excess recurrences and deaths in the minimally invasive arm of the LAC trial. What do you think about this? You think it's ethical to do this study?
You know, I think, first of all, I want to really just thank you for all the time and effort you have put into making this happen. This was truly a labor of love. And so really, we're so lucky to have you championing this trial. I mean, I think, you know, this is one of the biggest criticisms of the LAC trial, that they didn't really control for, you know, the, tumor and the tumor kind of in terms of delivery. So I think this is going to be really important in really controlling. And I think for that reason, this trial is going to be really important because, you know, if we can achieve the same outcomes with minimally invasive surgery, I mean, that's the way to go. There's right. So at present, you know, we don't have that data, but, you know, I think this is an important follow-up trial. So you know, I always say I am driven by the data, and I will do whatever is the right thing based on the data. And so this is I think a more thorough assessment of the issue. And I think we'll have a concrete answer once this is done. And I'm really excited that we have this trial going.
Yeah, I'm really excited too. And I'll tell you who else is excited besides Doctors Lateo and Bixel, our members. Our members have been extremely excited about this study. And so, you know, a lot of the inertia in the beginning of trying to get this going was just naysayers that this is not ethical. You'll never get this past an IRB. This really, and you know, we haven't put it through. We've gotten it through the central IRB WERB. We need to get it through the local IRBs, but you know, we really didn't have any trouble getting it through the central IRB. And our investigators are really excited about this study. Some of them are already practicing these tumor containment methods. Very soon, in the next month or so, month or two at the most, we're going to have our first investigator meeting, and Doctors Lateo and Bixel are literally going to do the road show to help investigators do these methods very proficiently and in a standardized way, so that we're all doing the same thing, and they're sort of viscerally like committed to getting this done and to getting it done right. And you know, similar to the Groins V studies, there's a very sophisticated surgeon qualification process that has to be documented prior to being on the study. And I'm not, there's so much detail, I'm not doing it justice here, but just in the interest of time, like if you're, you know, interested in this study, definitely reach out to myself or Mario or Kristen, and they can get you on board. And, you know, we're going to have 80 sites for this study. We've already got over 60 in the United States that are really raring to go to do this trial. And that's more than we typically see for our cervical therapeutics studies. So everybody's really excited about this trial. Great. Well, I think that's all we have. That's a lot. And there's so much that's happened in cervical cancer. And, you know, I think my end of year wrap up next year I won't have quite as much to talk about because we're all trying to figure out, okay, now what's next? So much has happened. But it was really nice to have the time to talk to everyone today about what's been happening this very exciting year for cervical cancer. And so great to have you, Bhavana. Thanks for joining me today. Your comments are so helpful and spot on and just really insightful. Thank you so much.
Oh, thank you for having me. And I just want to echo, right? So, you know, with all the PARP inhibitors, like ovary had its year, and then with endometrial cancer, we had, you know, we changed the treatment landscape with checkpoint inhibitors. And I think this is really the year of cervix. And, you know, so much has happened, and it's so exciting to move checkpoint into the front line, to have, you know, a really effective therapy like TV with such a, you know, duration of response, and then all the exciting things that are still yet to come. So, you know, thank you again, Leslie, for really spearheading this portfolio and everything you do. And I'm honored to be speaking with you about all these trials. And I want to wish everyone happy holidays and to an amazing 2022.
Cheers to that. Cheers to that. And thank you for that, you know, kudos, but I'll tell you, like, I'm looking for the day when I don't have a job or when I can do better, give you guys an endometrial and ovary more help, because the best immunotherapy for cervical cancer is a vaccine that's safe and available. And I think if we all saw the SGO news last week, cervical cancer rates are actually going down in the United States. And I hope that's not like a reporting blip or some crazy COVID thing, but I hope that's real. And, you know, 2006, the vaccine was approved. It's been out there long enough that we're going to start seeing the impact of the vaccine. And if that's the impact, that's really exciting.
Right. And that was in the JAMA pediatrics. So, and it was in young women. So it's really working. And, you know, everyone should get vaccinated. That's a great point, Leslie. My son got vaccinated at 12. You know, the earlier you get the vaccine, the better it is. Women and, you know, boys and girls, women, everyone should get vaccinated. You can now get vaccinated until you're 45. So obviously, the earlier you get it, the greater the immunogenicity. And I think that's a perfect way to end this. Everyone should encourage vaccination, and really, you know, having this vaccine is probably the most profound discovery we've had in GYN cancer, and we should really try to prevent this cancer. So you know, hats off to you for saying that.
So that's our Christmas gift to everyone. If your child hasn't been vaccinated, get them vaccinated. Just like you said, boys, girls, put us out of business here. We have other things that we can focus on and work on, and we'd be happy not to work on cervical cancer anymore. Great. Thanks, Bhavana. Happy holidays.
Thank you. Happy holidays.
Bye.